So good morning. My topic is under and over diagnosis, failure of machine or man behind the machine. So to define glaucoma, glaucoma is a chronic progressive optic neuropathy characterized by topical optic nerve head appearance with correlating RNFL defect, correlating visual field, and for this, IOP is the most important risk factor. I think we are in the privileged world because we are having so much of machine and technology. But before using these machines to diagnose any kind of disease, we should know about the machine. We should know little kind of software and algorithm about the machine. So in day-to-day clinical practice, it is not uncommon to see glaucoma in non-diagnosed glaucoma cases, and also patient is on over treatment, patient on treatment, and those patients are actually not having glaucoma. So to look the prevalence worldwide, approximately 50% of the glaucoma patient are overly diagnosed and was on the anti-glaucoma medication, and also the 50% of the patient are under diagnosed. India is not apart from this, and India is having 90% of undiagnosed glaucoma. So, and this issue are getting more complicated for those patients who are non-compliant and who are on not regular follow-up. So what could be the effect of the overdiagnosis and underdiagnosis? Underdiagnosis of the glaucoma will lead to progression of the disease, and ultimately it will lead to blindness, and overdiagnosis will lead to the overtreatment, which will cause the financial burden, also the psychological burden to the patient, and it will cause side effect related to the drugs also with the preservative. So what are the factors contributing to the overdiagnosis? It will be the fear of loss of vision, reliance on the newer diagnostic tool, misinterpretation of the test report, introduction and marketing of the newer molecules, like so many drugs are about so many drugs it is told that is neuroprotective agent, but still it is under debate, and also not last and the least medical legal concern. What are the factors contributing to the underdiagnosis? Also, it is the patient-related, like lack of awareness and inaccessibility to the health facilities, and also the ophthalmologist-related, like lack of resources. So many of the clinics are running on the short tonometer, and in the busy OPD, it is sometimes difficult to look for a comprehensive eye examination. So finally, who is responsible? Either machine or man behind the machine. So in this instruction course, I will be discussing about this. So it is very important for almost all the patient to do a comprehensive eye examination, which will include the slit lamp biomicroscopy, detailed fundus examination, including the assessment of the optic nerve head, gonioscopy, and measurement of the IOP. In suspected cases, we must do Goldman applanation tonometer. And if we are suspecting or we are diagnosing glaucoma patient, we should do OCT and visual field analysis. So various study has shown prevalence of undiagnosed glaucoma is more than 50%. And in this study, there is a telescopy eye study. In that study, it was self-reported glaucoma, which was having prior diagnosis of glaucoma, who was on the previous medical or surgical treatment. The prevalence was 2%. But when this study has included those patients who are having high pressure, high IOP, then the prevalence was raised from 2% to 5.5%. And surprisingly, 60% of those patients were not confirmed on subsequent analysis or detailed analysis. So when these glaucoma patient will be misdiagnosed, either IOP is high or in the normal range. So any kind of high IOP, or if we are suspecting glaucoma in normal IOP patient, we should do intraocular pressure measurement, definitely by applanation tonometer, and this IOP should be correlated with the pachymetry, because we have to adjust the intraocular pressure with central corneal thickness. Second is, and I think this is the most important part, assessment of the optic nerve head and the retina. And most of the time, glaucoma was misdiagnosed based on the increased cup-disc ratio, and about 20% are misdiagnosed and inappropriately treated as glaucoma when that diagnosis is based on the large cup-disc ratio. So in the optic nerve assessment, we should look for the size and shape of the disc, cup disc ratio, neoretinal rim, nerve fiber layer abnormality, retinal fiber hemorrhage, and peripapillary atrophy. So in this nice picture, we can see cup disc ratio is increasing, but the disc is non-glaucomatous because neuroretinal rim is healthy. But in this picture, we can nicely see this one is a small disc, but it is having inferior RNFL defect. This is almost 0.6, 0.7 cup disc ratio with inferior retinal fiber layer hemorrhage and subsequent NFL defect. And this is also around 0.8 cup disc ratio with inferior notch and nerve fiber layer defect inferotemporally. So it is very important to look for the disc very carefully, and it is important to, for documentation, we should do the fundus photography also. Optic coherence tomography, I think this is the most important and most commonly used tool in day-to-day practice, and this is used for the diagnosis as well as the follow-up of the glaucoma patient. But before using the OCT, we should know about the anatomical as well as the physiological variation of the disc, like previous instruction course, the myopia patient was discussed. So we should know the anatomical variation of the optic nerve head also. So based on the OCT, there is a disease called as red disease and green disease. Red disease are those diseases which are falsely positively diagnosed glaucoma due to incorrectly indicating the red in the corresponding image when there is no damage. And the green disease are false disease diagnosed when the software interpret actual glaucomatous damage as normal picture. Like in this, we can see this is the increased cup disc ratio around 0.7, but neuroretinal rim is healthy, but OCT is showing the red disease. Like in the left eye, we can see the red picture in the left eye temporally. Green disease, like this in the right eye, we can see the inferotemporal small RNFL defect, but the OCT is showing the normal picture. This is called as green disease. Subsequently, the visual field is used to diagnose glaucoma. Also, we will able to see whether it is stable or not. So in the visual field analysis, we have to look for whether it is normal or abnormal, which is based on the p-value. If it is abnormal, it is disease or not, which is based on the prior probability. And subsequently, if any visual field defect is there, we have to correlate with the optic nerve head finding. Like in this picture, we can see the optic, this is the visual field defect, superior dense arcuate scotoma, but the optic nerve head was healthy, and actually this is because of the ptosis, and when the visual field was reperformed with taping of the upper lid, the visual field was normal. This is also a visual field analysis of the inferotemporal VRVO, which is showing the superior arcuate scotoma. So how to prevent over and under diagnosis of glaucoma? We have to increase the public awareness. Comprehensive eye examination is compulsory. Judicious use of the machine. Proper infrastructure and training should be there. And evidence-based approach also should be there. And also there is regular eye examination. So nowadays we are living in the privileged world that we are having so many machines. So we should use machine judiciously. When we have to use, how we have to use, it is depend on the man behind the machine. So it is upon us how we are using the machines judiciously. Thank you.
Thank you, Dr. Praveen. In fact, it is very important to understand that the clinical correlation with all the findings on the tools which we are using need to be there in order to make a proper diagnosis. If there is discrepancy between the clinical finding and the findings which are present on the instrument which you are dealing with, then you have to revisit your clinical findings again. Any what do you want to put?
I have a question here, sir.
Yeah.
Recently, I came across a patient where the visual field parameters, like where the reliable field, it was showing a normal field. No, the OCT was normal, but visual field defect was there. So where exactly the things, I mean, how to go ahead with this? And we repeated this test like over a period of a month, getting consistent result.
I think we should look for the optic nerve head first, whether it is correlating with the field or not. Sometime, most commonly, nutritional optic neuropathy or toxic optic neuropathy showing the central scotoma because of the loss of the papillomacular bundle. In such cases, the optic RNFL OCT is almost normal. But when we are doing the GCIPL in OCT, it is completely showing the loss of the papillomacular bundle. Again, in this we can differentiate whether it is because of the diffuse loss of the papillomacular bundle in GCIPL. But in case of the glaucoma, when there is a loss of GCIPL bundle, there will be a Raffi sign, that is complete demarcation from the superior arcuate and the inferior arcuate even in the OCT also. So even if such kind of patient we are seeing, we should, I think we should correlate with the optic nerve finding with OCT and with visual field.
One more important thing in these cases, I think, is constant follow-up. If the clinical finding is not correlating with the visual field, then we have to see whether there is any progression or not in due course of time. If there is progression, then naturally we have to deal with the case. You want to add something?
Field
is
was
there.
normal.
Field defect is present.
Field defect was there, but OCT was normal.
So I think I'll agree to both, I think Vibhuti sir and Dr. Praveen. So if the pressures are normal and your disc is appearing healthy, you can just keep under 6 monthly follow-up and we don't need to treat. And just doing a basic investigation to exclude any neurological cause or ischemic cause will be helpful for these patients.
Right. And in general, like this is the group where we find all these vasculopathy also. Like if there is a case of BRVO, right? So old BRVO, suppose if we have, how reliable is OCT RNFL in these cases? Like.
Not very reliable, because if there is a localized area of BRVO or a scar, those areas you will have a chorioretinal atrophy, and associated in those areas you will have a RNFL thinning also.
Yeah, right.
So a lot of these patients will show RNFL thinning corresponding to the area of BRVO. In this case, you can't use OCT for diagnosis, but if you're following up this patient and you're seeing disc changes or a progressive thinning
Then it would be
in the
fine.
OCT, then it may be of some help.